I'd like to thank the organisers for giving me this opportunity to talk about demedicalization of PrEP, which is something that I am very passionate about, given how instrumental it was in APACC New South Wales. So I've been asked to kind of address 3 key questions. What's meant by the demedicalization of PrEP? Why should we actually be demedicalizing PrEP? Why can't we just give it in a clinic? And what are the options for demedicalized PrEP? Now, before I start with the heavy information, I want us to get to know each other in the room a little bit better. So I want you to all get out your mobile phones. How often do you get asked to get out your mobile phones in a conference? Get connected and go to Menti, www.menti.com, and enter the code. So we have, a minute or 2 for everybody to get settled. And just to start off, I want to know where everybody is from. So I'll give you kind of 15 more seconds to log in. Fastest fingers first. There we go. Philippines representing. Okay, 5 more seconds and then we'll move on to the next slide. Okay, next slide. And what is your main role in HIV? Who's in this room? Are you a physician? Are you a nurse? A pharmacist? Are you a researcher? Sorry, that should say researcher, not research. No pharmacists. I think we need to do more to get them into HIV. Okay, so next slide. And who, in your opinion, before we even start this, should be able to provide PrEP? And you can choose more than one option. You don't have to. Okay, that's great. So we might come back to this at the end. So what is demedicalization? I've just asked you a question on it and I said who should be able to provide PrEP, but what do we mean when we're talking about demedicalization? Demedicalization is also known as task shifting or task sharing, and WHO released some guidelines in 2018 on task sharing, task shifting for HIV services. And they defined it in a very academic way as the rational redistribution of tasks among health workforce teams, where specific tasks are moved where appropriate from highly qualified health workers to health workers with shorter training and fewer qualifications in order to make a more efficient use of the available human resources for health. One of the features of task sharing is really that efficiency and recognizing that there are many different tasks that can be performed by different health workers. Now, we know that PrEP is highly effective. In 2015, WHO recommended oral PrEP containing tenofovir is offered as an additional HIV prevention choice for people at substantial risk of HIV infection as part of HIV combination approaches. However, PrEP is needed as an additional tool to prevent, to achieve our 90-90-90 targets. PrEP is one of the 5 pillars of the UNAIDS combination prevention, prevention. And the WHO in 2016, together with UNAIDS, it's actually UNAIDS target, set a target for 3 million people to commence PrEP by 2020. That's a big job. And our current PrEP access and uptake is not sufficient to affect the course of the epidemic. As you can see here on the slide, our target is 3 million. Our current PrEP use, estimated by APACC earlier this year, was around about 500,000, and largely in the US. In Asia Pacific, we have far fewer people accessing PrEP. When you look at the initiations by country, you can see that we have in our region a lot of countries with high prevalence and quickly increasing HIV epidemics, such as in the Philippines. Our PrEP uptake and PrEP availability is incredibly small. There are many countries where PrEP is not formally available. And in this map, it also doesn't include informal access, which we do know is contributing to some uptake, but not very much. So we don't have very good access and we don't have very good uptake for PrEP. We need it for 90-90-90. We need it to end HIV as a public health threat. So why are we talking about task sharing for PrEP? Or what is it in the context of PrEP? So task sharing is an additional people-centered approach for preventing PrEP access. It's we know that existing services have the skills and expertise for PrEP, but many HIV-negative people experience challenges in accessing them. We've seen so many examples from Thai Red Cross and from others that show the benefits of approaches that are not in our typical clinics. Task sharing for PrEP is really about diversifying providers and service delivery sites to make PrEP more available, accessible, acceptable, reduce stigma and discrimination, empower PrEP users and increase efficiency. Optimal PrEP scale-up will require the diversifying of models of PrEP available, learning about the best features of each model and providing choices to clients to enhance engagement and uptake. So why is PrEP appropriate for task sharing? PrEP initiation and follow-up does not need to be done by a specialist. PrEP provision is generally protocol-driven and it's straightforward. Most potential PrEP users are healthy and they can self-manage. Physicians are required for complex cases, clients with comorbidities, certain comorbidities or concomitant medications, complex test results. There is an important role of physicians. And task sharing has been successfully implemented for other HIV services and other services in different countries. This is not a new or revolutionary concept. We've been talking about it. We've had guidelines for task sharing since 2008, before PrEP existed. So this is really something that we're just bringing into a new technology. So as I mentioned, PrEP is largely protocol-driven, making it very amenable to task sharing. There is no variation in dosing, and only a single drug is often available in a country. The parameters for suitable patients and behavioural clinical eligibility are well defined. Parameters for referrals are easy. There are few contraindications, low toxicity, and few side effects. So contraindications being HIV positive or having signs and symptoms of acute HIV infection, having poor renal function, or there is one more which is just escaped my memory, but basically there are 3 other major contraindications. It's pretty simple. Allergy to drugs in the regime. And enrollment and monitoring and follow-up procedures are standardised. So this is an example in the table from Sydney Sexual Health. As you can see, it is very much a checklist. It is very easy and protocol-driven. But I want to emphasize that PrEP care is a package, it's not just a pill. There are recommended tests including HIV, creatinine, hepatitis B, STIs, and hepatitis C, which may be at baseline and or at follow-up. And comprehensive support is also required, but this is all part of that checklist. It isn't very complex. So I've been given the task to really talk about some of the different models of PrEP service delivery. And one of the most obvious is, and the ones that I'm going to be talking about are the non-physician-led, obviously, models of service delivery. So nurse-led models are some of the most obvious. When it comes to task sharing for many other conditions, we often think about nurses as the next kind of healthcare worker that may be empowered to take on client management. In APACC New South Wales and Australia, demedicalization of PrEP and nurse-led models were essential to the success of the project. APACC New South Wales was a government-funded implementation trial, and it was a New South Wales government priority. We were aiming for rapid statewide scale-up of PrEP with high coverage to achieve a significant public health impact in reducing new HIV infections. And this was in the context of despite high testing and treatment, we hadn't experienced a decline in HIV infections. We'd achieved 90-90-90. We didn't get that decline that we were expecting. And because it was government funded, there were limited resources. So it had to be close to the real world. We had stretched clinics. They were already busy. All of our clinics are already busy. And so the majority of clinics were public sexual health and HIV services, and they were free to clients, so they weren't charging. And it included clinics without on-site doctors in rural areas and community testing sites to expand access, but of course that created a need to innovate in the way that we were doing our service delivery. And so we needed, combined with the rapid enrollment, the high numbers of people, and the fact that we didn't always have services with doctors, we needed to innovate, and nurse-led PrEP was one of those innovations. Nurse-led PrEP, importantly for us, nurse-led PrEP was not prohibited under we had to do it as a clinical trial, our clinical trial protocol. But we did need a legal instrument. We needed authorization from the Ministry of Health to allow nurses to prescribe PrEP or to provide PrEP. They weren't allowed to prescribe. So under the nurse-led model for PrEP, trained and authorised registered nurses at public health clinics were delegated responsibility by the PI, usually a physician and the head of the clinic, under the protocol to be able to screen, educate, clinically assess, order test results and manage those results. So the full PrEP package nurses were authorised to provide. And they supplied the daily TDF-FTC, which is what we were using in the trial, under a standing order. That standing order did need to be countersigned by a doctor within 24 hours, and there was a requirement for at least medical review, although we weren't prescriptive about what that review had to look like. Now, this is the scheme of the model, and one of the key features is that we had different models. It wasn't just a nurse-led model. We had clinics that were regular clinics where the PrEP session was done within 30 minutes. We had express clinics, and we had a community-based testing sites. And really the difference in the sites was, one, how long your appointments were, how streamlined it was, but two, the presence of auxiliary or support staff. So in an initial consultation, the full range of services was provided, and that could be provided by a nurse. There was a clear referral pathway for abnormal test results, or where people were otherwise complex and an appointment was made with a physician. Where people, particularly after an initiation appointment, were otherwise uncomplicated, they were offered an express clinic, and we used computer-assisted questionnaires to streamline even further, and a registered nurse was responsible for providing those services. So it was a very streamlined process, and it was really instrumental in allowing us to enroll about 10,000 patients within 2 years. But without that additional workforce, it would have been incredibly difficult to have such a rapid enrollment. So we were enrolling far more than 100 patients a week. And it was instrumental in contributing to a massive decline in HIV diagnoses in MSM after PrEP was implemented. So in the 12 months after the first 3,700 patients were enrolled, we experienced a 32% decline in recent HIV infections, and recent HIV infections are the ones that you really want to look at. You're not preventing an infection with PrEP that somebody acquired 10 years ago or 5 years ago. You're preventing the recent infections. So this was really quite a success, but Nurseled Prep allowed this to happen so quickly, because one of the really important features of PrEP is not just the personal benefit, but also the herd effect in interrupting onward transmission. So you get enough people on PrEP at a time, you really disrupt those transmission networks, and that's what we saw. Now, APACC New South Wales and now Nurseled Prep was not the only or even the first nurse-led model. Prep Express at 50 Dean Street was also using Nurseled Prep, and they found that it was instrumental in also reaching their targets for the PrEP Impact trial, So their model was quite similar to ours. They had a reasonable history of providing PrEP since 2015. They had doctors supporting patients who ordered PrEP online. With the increase in patients who were ordering PrEP online, they needed to really empower a range of staff to provide those services. And their nurses were already leading STI clinics since 2014. So with PrEP, and with the PrEP Impact trial, they authorised their nurses to prescribe and dispense PrEP, expanding their nurse-led model. So anybody, similarly to APACC New South Wales, anyone with a complex medical history requiring further medical assessment was booked into a physician-led appointment. So again, we have these clear referral pathways. Magnet in San Francisco is perhaps the world's oldest and largest nurse-led PrEP program, and it was a San Francisco AIDS Initiative launched program. Disclaimer, this is not a nurse from Magnet Clinic. Unfortunately, it was the best looking nurse I could find on Google Images. But it is entirely managed by registered nurses and nurse practitioners, including for initiation visits and follow-up. Referral to primary care, there is referral pathways for either non-PrEP related care or for specialists for complex cases. And they also provide that full range of PrEP services. So enough about nurses. Who else can provide PrEP? Well, pharmacists are incredibly important providers of PrEP. We know that in many cases, they're already starting to provide a lot of information and about other conditions. They're been shown to be very good at clinical protocols and following those. They're experts in medications, in drug interactions, and often have a little bit more time than our busy clinics. So the Iowa TelePrep initiative, under this scheme, clients were referred to Iowa University pharmacists by self-referral or other testing programs, and these pharmacists completed, this is a link of Demedicalization with technology as well, they completed video visits with patients, arranged local laboratory studies and mailed medications. And so they had 68% of people who were referred to them completed those initial visits. 91% were MSM. 91% of those clients with initial visits actually initiated PrEP. So that's a really good uptake from what we know from other studies. They had 61% retention at 6 months, which is pretty good, and 96% of their lab tests were completed despite the fact that they weren't done on site. So they did that arranging local laboratory studies. And 100% of their STIs that were diagnosed were linked to treatment within 14 days. So this was a really successful and acceptable model, and this model is still running. One Step Prep is another community pharmacy-based model, and again, as with many of these models, it required an authorization and an agreement for clinical governance. So they had a collaborative drug therapy agreement between the pharmacist and a medical director, specifying their scope of practice. And basically, again, it was the full range. So you can see here one of the features is actually providing PrEP as a one-stop shop, because we know that barriers to PrEP include multiple visits. So referrals were made by a range of different services into their scheme, and clients were referred to a physician for non-PrEP related care or PrEP related complications. And critically, their existing legislation within the state allowed for pharmacist reimbursement. One of our challenges, and I'll speak about this a little bit later, is actually funding these innovative models. So 97% of people who were referred to them initiated, or who were evaluated, initiated PrEP. 3/4 began the same day. They had high adherence. The effective dropout rate was 25%, which is very low, and they had no seroconversions among those linked to care. In any other scheme, this would be considered a very highly successful model. Key population-led PrEP. Now, I don't want to talk too much about this one because I have two experts here for the Princess PrEP program and another expert for PrEP Filipinas that are all different versions of key population-led programs. But really, as we've heard, key population-led programs are critical. They are acceptable to the population. They're co-created. They're designed for the population, by the population. And so they are also not operating in isolation. They are partnerships and true partnerships with clinical governance provided by local health authorities and or clinics and other providers. So Princess PrEP program, which is a Thai Red Cross initiative and incredibly successful, is one of, I think, is the first and perhaps arguably one of the most successful key population-led programs. And here, key populations provide the full range of services, right from reaching and recruiting and doing that initial community mobilization to providing, assessing risk, providing counselling, performing HIV testing, sending samples, dispensing PrEP to HIV negative clients on the same day, and again, based on a standing order, to consultation with a doctor and calling to inform of laboratory results and providing those PrEP follow-up visits. One of the critical features here is that when we're talking about key population-led PrEP, we're talking about lay providers. So this is further increasing the numbers or the types of people that can provide PrEP. And you can see with the clinic flow, it provides a really clear pathway. And all PrEP services do. PrEP is really simple to provide, where it's clearly indicated what to do based on what happens, when, and where referral is required. And the data suggests that the key population-led services are reaching high-risk individuals. PrEP is appropriate for people at substantial need. We want to make sure that the people who are accessing them are those who would benefit most from PrEP. And key population-led services, at least in Thailand, have been incredibly successful. People who are having multiple partners, group sex, condomless sex, and using drugs, in particular for the purposes of sex, are there are high proportions accessing these services. And Princess PrEP, or key population-led services, are responsible for about 55% of all people who have initiated PrEP in Thailand. That is a massive achievement. However, we have a long way to go, as I mentioned, with making sure that everybody who is at substantial risk has access to PrEP, even in Thailand with such a successful program. And finally, self-led PrEP. I like to think of self-led PrEP as the future. In this world, there is increasing empowerment of people to manage their own health needs, and it's gaining importance for chronic diseases. So there are many conditions are managed quite effectively in the home by somebody, and just with referrals to doctors as they need things and after diagnosis. So what could a formal self-led PrEP program look like? Well, we could consider HIV self-testing, Disclaimer, not currently recommended for PrEP. Or perhaps HIV self-sampling. STI self-sampling is already a feature in many places, or perhaps they could access testing sites in other places. Online access to PrEP drugs. Or perhaps there's a telemedicine kind of approach where they're sent a script. But it must have clinical support or access to clinical support. There have to be clear pathways and linkages to care. The protocol on how to do it and the guidelines need to be really clear. I don't know about you, but I don't really read the medication inserts. Occasionally I do, but I mean really, like, it needs to be simple. If it's not simple, nobody reads their VCR or their DVD programming instructions. Make it easy. And we need to consider whether it's appropriate for initiation visits or just follow-up, or maybe it's appropriate for both. And this is one of our new frontiers. But self-led PrEP is already happening. People are already doing it in your country, in my country. People are buying PrEP online. They're buying PrEP, they're banding together and having PrEP buyers clubs. They are using medication informally that they've accessed from a pharmacy in one or another country. Sometimes they're going to a clinic, they're getting supply for them and for somebody else. So we know that this is already happening. What we need to do is diversify the models and support the people who are doing it. So there are a lot of potential benefits of PrEP task sharing, and hopefully in this very quick presentation and overview, I've been able to show some of them. It diversifies the services, allowing PrEP clients to find a service that really meets their needs. And this is crucial when we know that PrEP access and uptake is already so low. PrEP is a crucial additional HIV prevention option. PrEP outside of specialised services provides a gateway to broader sexual health and other health care. It really allows linkage, and PrEP, one of the things that I love about PrEP is that PrEP is empowering. So PrEP allows people to take control of their sexual health, and so creating positive environments and demedicalized care can support all of this. It empowers clinicians as well, and other providers to work to their full scope of practice, and it builds the workforce capacity. And it concerns limited physician time for complex presentations. In clinical settings, nurses far outweigh physicians. We know that pharmacists also are really, they're in so many places that people can access them. They are in rural and regional areas where clinics and physicians are not or aren't necessarily available. And they're often open at hours that our typical clinics are not. It can make a more efficient use of our limited resources, particularly where funding is declining. And it really provides an opportunity for partnerships between providers and services, and for innovation. It supports client-centered care and empowerment, which I think is something that we're all aiming for. And the idea is that it increases uptake and retention where services are accessible and acceptable. So what do we need to do this? Scoping and planning. Initially I called this challenges, but it's not really challenges, it's opportunities. Scoping and planning is important. Ensuring acceptability to clients, to clinicians, to government, and to partners. Demedicalization is kind of a scary topic for many people because they feel like it will disempower them rather than empowering them. Co-planning with clients to ensure a client-centered approach, and ensuring the appropriate mix of service sites and providers, and this will differ by country. There are legislative, regulatory, and/or policy framework changes that are required. In some countries, nurses are authorised to provide STI services, some medications. In some clinics and in some countries, there are massive regulatory barriers that are preventing nurses from providing some of these services. So really looking at the opportunities and the challenges and where these changes can be made. We need to have clear protocols, guidelines, and referral pathways for PrEP to demedicalize it. But PrEP is really amenable to that. It is really simple. As any physician who has prescribed PrEP will be able to tell you, 90%, 95% of patients are really simple and uncomplicated. You do 10, you're super bored. Like it's does not stretch you. There'll be 1 in 10 maybe that is really interesting for a physician. Their ongoing training, strong linkage is really required, particularly those referral pathways, ongoing training and professional development, accreditation and certification of services to make sure that we have quality assurance of providers, integration for other services, and the availability of testing services. So we need to make sure that the logistics are all set up. And sustainability and financing for services and reimbursement. There are many legislative barriers that prevent other service providers from being reimbursed for their services. And in places like Thailand, we're overcoming some of those, but there are many places that still have a very prescriptive way that reimbursement happens. If we really want to roll out PrEP, we need to start looking at these different ways. So this is a quote from the San Francisco AIDS Foundation about their magnet clinic, and I really love it. Seriously, use nurses, pharmacists, peer volunteers, and anyone who is able to support you to support your PrEP program. And there's another quote that I love, which is from one of our co-chairs, which is that PrEP can be demedicalized safely, efficiently, and innovatively through various providers and service delivery sites. The medical profession and national and local public health policy and decision makers should accept that demedicalization of PrEP is happening. Stop trying to control it and look at how best to facilitate its uptake and scale up. Together, we can actually make this happen. So I would like to, a lot of this data came from a lot of other people, so I'd like to thank everybody who contributed slides and who was involved in the presentation. Thank you.